Thanks for tuning in to the Red Clinic Podcast. I'm Dr. Schwalen, licensed psychologist and expert in the treatment of eating disorders. Today, we're going to do what we do best and provide education on eating disorder treatment and things that will help you and your loved ones. I have a very special guest joining me today, Liesel Sumpter, registered dietitian, and a very valued team member at the Red Clinic. Thank you so much for joining us today.
Awesome. I'm happy to be here. Thanks for having me.
Absolutely. So today, what I want to talk about is actually something I've addressed in previous episodes, but because it continues to come up in different ways and it's just a really important topic, we're going to talk about it again today and maybe say things in a little bit of a different way because we want to find ways to reach people in as many ways as we possibly can. The topic we're going to discuss today has to do with higher level of care referrals. So what I mean by that is if a provider gives the recommendation that, treatment at the outpatient level, which usually is like once a week therapy session, once a week nutrition if possible, when a dietitian can be involved, whenever that level of care is just not enough or not what's needed for the severity of an eating disorder, and the person may need more than that, right? It can be very difficult for the person or their family or their loved ones to accept that recommendation. And we see it often. We're seeing it now, I think, more and more these days, especially because there's just a lot of wait lists that we're coming up against at different hospital settings. The pandemic has made life really challenging and stressful, and so more and more people are seeking out mental health help. And so clients are really pushing back a lot on recommendations that we make for going to the hospital. Have you noticed that that's been happening?
Absolutely. Yes, I think the proportion of people being recommended is higher, but also the pushback is definitely an issue as well.
Right. And when I say pushback, I mean, there's that leading with fear of, well, what is this going to mean in terms of logistics or my work schedule or prioritizing my school schedule? The idea that those are barriers to taking that next step to get the true level of care that someone needs, that's what's coming up a lot. And I want to normalize that. It's pretty normal to have those thoughts and worries. If a doctor tells you, hey, I really think that you're severe enough to the point where you need hospitalization in order to actually recover from this, that is a huge piece of news. It's a lot to wrap your head around it. And it's okay to go to that place of, well, what about school? What about work? What about my kids? What about my life? I mean, am I just expected to put my life on hold and do this? How is that even possible? That's really normal. The part that is concerning and the part that I want to talk about today is when it's really not just about that initial anxiety, because we can problem solve all of that, right? The problem is when the recommendation is made over and over again and the client or the family remains in denial. Okay? So what's at risk when someone chooses not to take the recommendation for a higher level of care?
From the medical and nutrition standpoint, there is a lot at risk. If we've recommended an evaluation with another treatment center for a higher level of care, it means that right now someone's body is not stable enough to do just weekly client care.
Okay.
Which means that some serious medical complications, and with eating disorders, that does include even up to death, that's what's at risk for not going.
Okay. So let's actually break that down, right? Because earlier today, we actually did a training and we were talking about, for example, medical complications associated, I think it was with bulimia, or maybe it was anorexia. I'm not sure which one we were talking about at the time, but you had mentioned something about the tissue around the heart, for example. Do you remember when you brought that up? I think things like that are really powerful to break it down for anybody to really understand how serious these side effects of malnutrition can be. So would you mind if we just go into that a little bit today?
Yeah, absolutely.
Okay. So what are some things that are associated with anorexia and bulimia?
Yeah. So with anorexia in particular, anytime the body's not getting enough nourishment is when malnutrition can occur.
Okay.
Malnutrition means that when we don't have enough food and calorie intake, the body has to use its own forms of energy to sustain itself. So it's going to use fat tissue, muscle tissue, even break down bone tissue and reuse those things in the body so that we can keep running because the body is good at that. However, past a point of time, that means that as that tissue continues to deteriorate is when we can see effects on our organ systems. So specifically with the heart, that means that because the heart is a muscle tissue, the body is not going to discriminate against heart muscle and a skeletal muscle past a certain point. If the skeletal muscle has been used for energy, you can start losing heart muscle tissue. And with a weaker heart is where we see complications like heart failure, even up to the point of death with anorexia.
Okay. Any other examples when it comes to medical complications? Because I think just what you said right now is like shock factor, right? And a part of this podcast is really meant to shock you. I mean, it's the purpose behind doing this episode is because we have several clients, right, that need a higher level of care at this time, and they reach out to us week after week, just delaying their admission because they're struggling with their own denial. And so part of making a good decision for your health is to have information and be educated. And so we're trying to help people make an informed decision for their best interest. So what else can you share about how serious the health complications can be?
Yeah, for anorexia in specific, things like osteoporosis are unfortunately irreversible. And when you consider the population of, a large proportion of people struggling with anorexia are typically female, although that's not always the case. Anyone can struggle with an eating disorder. Females are gaining peak bone mass until about their early to mid-20s. After that point, the bone mass you have is what you have, and you just got to do your best to preserve it. So if an eating disorder is interfering with someone's ability to get enough calcium, vitamin D, preserve their bone mass, that's when we're going to see bone loss. And we've seen clients as young as 12, 14 years old diagnosed with osteoporosis. And that's something that's never going to change as a direct result of having anorexia.
Okay. So far we've talked about the two irreversible side effects of anorexia, death and osteoporosis. Are there any other irreversible side effects?
For anorexia, those are the two main ones. However, the reproductive system can be affected. It's not always sure or predictable how someone's individual body is going to react, but long-term infertility is something that some people may experience as well.
Okay, and that can be irreversible as well.
Yeah.
All right. So let's talk about the psychological piece to this, just so I can throw that in there. Because another thing that we like to really educate on is the fact that, although these side effects of malnutrition absolutely can and do occur in clients with eating disorders, a lot of the time it can take a while for these side effects to really show up, okay? So what you were describing is, in the beginning, it starts off as I'm going to just use this phrase because that's just what I keep thinking is the body's eating itself almost, right? And so maybe in the beginning, there are no signs of that in blood work, right? We've seen that many times. We might ask for certain blood work to be drawn and the body hasn't maybe shown those signs yet. The body's adapting. It's doing what it needs to do, aka eating itself, right? And so medically, someone may look okay from a lab work perspective, but psychologically, we know that where their thought process is, the way they're feeling, the types of preoccupations that they're experiencing when it comes to, only being able to think about food or body image or burning calories or engaging in obsessive or compulsive behaviors to the point where it's interfering with just daily functioning, that's also a sign that the eating disorder is to the point where we're not really going to be able to treat that or stabilize it outpatient. So a higher level of care referral can still be made even if medically the person is not in that emergency state yet. Mm-hmm. When we make that referral as the providers, it's because we're taking into consideration everything that's going on, and then also our understanding of what the long-term impact may be if they don't get help now.
Absolutely.
So we're really trying to prevent some of those other things from happening by sending them up to a higher level of care.
Absolutely.
Okay.
And even if a client hasn't had anorexia for a long-term period of time, to see some of those potentially irreversible effects, if someone is going a while without eating, so essentially starvation, the body and how it manages our electrolyte levels is actually going to be at a high risk of what we call refeeding syndrome. If someone just, leaves the assessment and tries to go eat again, the body's going to be flooded with nutrients that it hasn't had to handle in a while, which causes shifts in our electrolytes and can lead to severe things like shock and potentially heart attack. Another reason why we might make that higher level of care recommendation, even if, it's only been a few months, someone hasn't been struggling for years and years with anorexia, is that we want them to be in a setting where they're safely monitored during that refeeding process and not doing it on their own, so that we can watch the electrolytes be back in balance. And that's also something we can't do at an outpatient level because we don't provide 24-hour care if someone needs refeeding assistance.
Now, I'm so glad you brought this up, right? Because I have seen this many times where clients will come in for the initial assessment, or maybe they've even been having therapy with us for a while and they're just no longer appropriate for outpatient and they need a little extra support. And instead of going to the hospital the way we recommend them to do, they decide to start eating more on their own. And you're saying because of refeeding syndrome that that's actually very dangerous, that is not the recommendation. Going home and eating more and just changing your meal plan overnight unmonitored is not what we're saying to do. I see this so often where, I might have kids or adolescents in my office and they hear the discussion about the eating disorder. They start to understand that they're meeting criteria for a certain diagnosis. And then that night they go home and they start eating again. And parents get excited. They're happy that they think this is a sign of progress. However, what they don't understand is that it's actually something that could be very dangerous for their child. Adults do the same thing. Adults will kind of have a conversation. It builds some insight for them. Some light bulbs go off. And then they go home and decide that they can do this on their own. And we're recommending, no. If you have heard that you're supposed to pursue a higher level of care admission based on our data and our assessment, we're saying you can't do this alone. Like, you're at that point now where you shouldn't try to do this on your own. Right?
Absolutely.
Now, one thing I do want to add too, because you brought up refeeding, is that the rigid nutrition that somebody has by the time they get to us, right, and may be at risk for refeeding, in turn influences even more rigid thinking. Okay, this is where the psychological piece really comes in. So rigid nutrition leads to rigid thinking. Rigid thinking leads to more rigid nutrition, and more rigid nutrition continues to lead to rigid thinking, and on and on and on. And it's a trap, okay? And clients really get stuck in that trap. So the ideas of, these are the only foods I can eat, or this is what's good for me, and I can only have this many calories per day, especially if we're dealing with anorexia, right? Those rules get obsessive. They become preoccupations. They become to the point where it's all the client can think about and it runs every decision during the day and ultimately in their life. And those are the signs as well from the psychological or the thinking perspective that would make someone, like me say, this is not appropriate for outpatient. We really need a hospital level of care. I just wanted to throw that in there.
Yeah.
What are some other things? So, I know we've touched on anorexia. Let's talk about bulimia a little bit.
Yes.
So what are some medical complications with bulimia that are really serious and require hospitalization?
So medical complications caused by bulimia, and that specifically is going to refer to any time there's purging, binging and purging going on, and that can be via self-induced vomiting, using laxatives or diuretics, or even purging through compensatory exercise, so excessively exercising. That is putting a lot of strain on the body. Our bodies are not meant to vomit frequently. And so anytime there's that much acid going around the stomach, the esophagus, through the mouth, all of those tissues are going to see really, really damaging effects. So a common one people know about is dental damage, whether that's tooth decay or sores on the inside of the mouth. But in the esophagus and lining of the stomach, that constant exposure to acid can over time cause wearing down of that tissue to the point of even tearing or rupturing. This is one of the most serious complications of bulimia that we watch out for, and even recommend that people go to the emergency room immediately if this happens, because if it has torn, all of that stomach acid and stomach content can leak into the body and cause serious complications like sepsis. So we tell people, if you ever see blood in your vomit, go to the emergency room immediately. But those are complications where you could need surgery for that. We can't deal with that at an outpatient level. If someone is purging multiple times a day or even multiple times a week and at risk for these complications, we need to make sure that they're in an environment where people can watch out for this and really help to minimize those behaviors.
Okay. And this is so serious that when we ask this question during the initial meeting, if the answer is yes, we stop the assessment and we say you're not in the right place. You need to go to the emergency room right now, right? And so essentially we're taking that step to help save that person's life. I'm glad that you said, they need to be in a place where these health complications can be managed appropriately. That leads me to just kind of want to educate a little bit on what to expect at a higher level of care. There are therapists and psychologists and dietitians, so more people like us, right, in a place like a hospital setting that specializes in eating disorders. There's also going to be, in most places, physicians and psychiatrists, nurses, medical support where, like what Liesel had mentioned with refeeding syndrome, blood work can be monitored on a regular basis. And we say regular, we're talking like every 3 days, every week, every, 14 days, whatever it is, but on regular intervals, it's able to happen because in a hospital setting that's set up for the treatment of eating disorders, all of these providers are there under the same roof, working together as a team, and they only have one goal in mind, and it's to get your loved one or you, if you're the person with the eating disorder, into recovery.
Yeah.
Anything else with bulimia?
So bulimia can also see some of those serious electrolyte imbalances as anorexia. However, the symptoms are what causes a different intensity. So anytime, again, that there is a lot of vomiting or use of laxatives, so potentially diarrhea, it means there's a lot of electrolytes leaving the body. And if those aren't adequately replaced, then we can see those same shifts in electrolytes that at worst cause things like a heart attack. And so again, we want to make sure that someone's body is safe when these things are going on so that we don't see things like metabolic alkalosis and hypokalemia.
Okay. And so essentially we're saying in a very long way that if we're sending you up to a higher level of care, it's because this is not within our competence to do this outpatient, right? We're being responsible as your provider. We're giving you a reason to truly trust us because we're not trying to take responsibility for something that we know is beyond our level of service at this point.
Yeah. And we're here to walk alongside clients through long-term recovery as they face things once their bodies have been stabilized.
Right.
And so going to a higher level of care, most likely, it's probably the shortest amount of time in their treatment for an eating disorder and recovery. But that's because the goal is to stabilize the body and the psychological elements that need more support. And then when someone is safe and ready, we walk alongside them in outpatient care for the long term.
That's true. I mean, we see most of our clients in recovery for 6 months to a year or more after they have completed the program at the hospital. And that's where a lot of the work and recovery happens is, they're reintegrated back into regular life. They're back at work or at school. They're home with their families, and they're still learning how to manage the eating disorder, but they're out of that that risk zone, that safe. They're safer for outpatient.
Yeah.
Okay. Should we touch on just side effects associated with atypical anorexia, avoidant restrictive food intake disorder, and binge eating disorder?
Yes.
Okay.
Yeah. Atypical anorexia is one I'm really passionate about sharing these medical complications with, because a lot of people just think you have to look like you have an eating disorder. And with anorexia, that typical image is a really underweight body. But that's just not the case. Someone can have the same medical complications of anorexia and malnutrition without being at a dramatically low body weight. And so, like mentioned earlier, that's things like osteoporosis. That's potential infertility. That's electrolyte imbalances and malnutrition that affects the whole body, even if someone doesn't look like they're drastically underweight.
And we see that with ARFID also, because individuals with avoidant restrictive food intake disorder can also have the same types of complications associated with malnutrition and yet not be underweight. They present either in their normal weight or sometimes even above their normal weight range, just like clients with atypical anorexia may. And so you're right. It's not about if someone looks sick enough in order to be sick enough to go to the hospital.
Yeah.
Okay.
And I know we've mentioned some of the bigger, more major complications, but with anorexia and ARFID, other ways this plays out is things like nutrition deficiencies. So on lab work, seeing low vitamin D, low vitamin B12, low iron, because they're not eating a wide enough and adequate enough range of foods to provide these nutrients. And within each of those nutrient deficiencies come more side effects that we could sit here and talk about.
Ooh.
But the main thing we want to communicate is that whether it's just lab work nutrition deficiencies or these really major complications, there are medical concerns if anyone's not eating enough.
Right. And then, excuse me, and then those medical concerns, the nutritional deficiencies can also impact mood concerns, right? And mood concerns and psychological functioning and in general functioning just throughout daily life can be extremely impacted if the nutrition isn't adequate. I said ooh earlier when you said, we could talk on so much more. I'm just getting ideas for future episodes, and that makes me very excited. Okay, so before we end today, is there anything that you want to leave or impress on our audience today?
One point I want to drive home is that when we're doing an assessment for a client and we recommend a higher level of care, sometimes we will simultaneously recommend go ahead and get some lab work done. We'll send those recommendations and coordinate with your physician. Sometimes we might stop the assessment and recommend they go to the emergency room. Recommendations like that don't replace our recommendation for a higher level of care. Those are just things we want to do immediately to make sure someone is safe. So even if a client had to go to the emergency room and then they're checked out and they're discharged from the emergency room in less than 12 hours, we're still going to recommend a higher level of care.
Absolutely.
And even if they get lab work done and it comes back relatively normal, because the body can do that, it's pretty resilient, we're still going to recommend a higher level of care to really address all angles of the eating disorder.
I mean, I'm so glad you said that, because we don't ever send mixed messages. And we're very, very passionate about that at the Red Clinic. And I think red is the color of passion. So maybe that's where it comes from. But we don't send mixed messages. If we are recommending a higher level of care, it's for a slew of very good reasons, right? And clients sometimes will come back to us and say, some of the things I mentioned earlier, well, I'm just too scared, or I don't want to give up on school just yet. Can we wait until the summer? Or I just got a promotion at work. I can't do this to my team. Can it wait? Or can you just see me for a little while? And they'll try to negotiate. I'll get on the wait list, but if I'm better by the time I get to the wait list, will you just continue to see me? I can't tell you how many times we've heard that as well. And we don't send mixed messages. We're not going to negotiate with your eating disorder. That's really all I can tell you. Yes, you're scared, but you're also struggling with anxiety. The anxiety doesn't ever see any relief because your nutrition isn't where it needs to be. Maybe you haven't gotten a hold of really great, effective coping skills yet. We're here to tell you, right, that there is actually relief for all of that. We know there's relief for it. We see clients go through amazing transformation. They're at the point where they may need hospitalization, but a year later, they're at the point where they're living their fullest and best life. And all of that is possible. It is truly possible to put an eating disorder behind you. It's possible to achieve the dreams that you want in your life and to recover from something like this. I have met many clients that are in true recovery that have really, really been at their worst, but honestly are in life now using all of that anxiety and perfectionism and even type A types of personality traits in positive ways, in healthy ways that actually help them instead of hurt them. And so I just want to leave that with everybody, that we don't make the recommendation lightly. When we do, it's for your best interest, and we do not recommend a delay in getting the appropriate level of care. Thank you, Liesel, for joining us today. I hope you come back soon.
Thank you for having me.
All right, there you have it. I hope you tune in next week.